Yeah, I think we can start. Dr. Shipra.
Okay, ma'am.
Dr. Rishita, stop screen sharing.
Good evening, everyone. On behalf of Indian Society of Anesthesiologists, I warmly welcome you all to today's ISA National Online PG class. I am Dr. Shipra Singh, attending consultant in Fortis Hospital, Noida, and I will be the screen coordinator for today's session. These classes are organized every Monday or Tuesday evening to strengthen the postgraduate teaching and provide national academic platform for all students. Let us begin today's session by invoking the blessings of Goddess Saraswati, the goddess of knowledge and wisdom, to enlighten our minds and guide our learning. Now I have the honor of inviting our respected Professor Sukhminder Bajwa sir, Honorary Secretary ISA, to say a few words before we begin the academic proceedings. Over to you, sir.
Thank you, Dr. Shipra. So we as a team are thankful to Dr. Vinay Kumar, Dr. Srilata Madam and Dr. Snelata Madam for arranging their team for presentation of this class. And this is a very important class of Peripartum Cardiomyopathy actually. I think when we started our career independent working in the OTs and when we face these cases, there comes the real challenge how to manage these cases. You are dealing with two lives at the moment, one with the mother and the fetus there. And when you deal with such patient, the knowledge of physiology, the pathophysiology, the cardiac tissue, how it behaves under stress, the variability, the degree of the cardiomyopathy, how it's going to affect. So many things are there. And definitely it always impact your anesthesia considerations also. How to take such patients, whether it during elective surgeries or during emergency surgeries. And also, I think the best way to deal with such patients is because these are just around at a particular period of 5 to 6 months in and around the pregnancy when the delivery is there. They can come out with any surgery also, postpartum also they can come with any surgery. And when you face such patients, it's become really challenging. May look uh, good for, I think, thinking like answering the questions in the theory part. But when it comes to the practical part,
Okay, sir.
I'm telling you, it's a very, very
Thank you so
difficult.
much, sir. It is now my privilege to introduce
So I
today's
think
distinguished
so. It's
faculty.
always
We have Dr. S. Vinay Kumar, sir, with us, the professor and head of the Department of Anesthesiology at Siddhartha Medical College, Vijayawada. Sir has a PG teaching experience of 20 years with special interest in trauma, pain management, and palliative care. Sir has been EC member ISA AP state from 2019 to 2022, Deputy Superintendent from June 2023 to November 2024, GGH Vijayawada, ISA President City Branch Vijayawada 2025 to 2026, Sir has been awarded Best Doctor Awards from District Collector 2020 and 2023. Sir has to his credit 18 research publications. Next, we have uh, Dr. Vengala Srilatha ma'am, who is a professor at Siddhartha Medical College, Vijayawada. Ma'am has a teaching experience of 18 years with special interest in obstetric anesthesia and pediatrics and ICU management. Ma'am has 10 publications. She has worked as Secretary ISA City Branch, Vijayawada during 2018 and 2019, during which she also got the Best City Branch Award. Ma'am has worked as Vice President at ISA City Branch, Kurnool during 2022 and 2024. And Ma'am is also an ACLS and BLS instructor. Next, we have Dr. Snehalata Bhashyam ma'am, who is Associate Professor at Siddhartha Medical College, Vijayawada. Ma'am has a teaching experience of 14 years with special interest in pain and regional anesthesia, PG academics, and scientific research. Ma'am has been a speaker in ISA state conferences and ISA zonal conferences with 13 research publications to her name. Before we proceed, just a few rules for all the participants during the lecture. During the lecture, all participants will be muted. In case you have any queries, kindly type them in the chat box and they will be answered in Q&A session. And also during the lectures, faculties will be asking questions. We encourage everyone to answer the questions in the chat box. And finally, all participants are requested to switch off their videos during the course of the lecture. With this, I now request today's faculty to kindly introduce the PG students and take over the session.
Good evening to all. Is it audible, sir? Is it audible, sir?
No, ma'am.
So, good evening to all. So, I am Dr. Srilatha, working as a professor at Siddhartha Medical College, Vijayawada. So, today the topic is Peripartum Cardiomyopathy. Thanks for giving the opportunity to speak on at the national forum. So, I will introduce my Snehalata madam, and our PGs Rishita and Devi, both are studying to second year PGs. So, introduce Snehalata madam.
Good evening, one and all. I'm Dr. Snehalata, Associate Professor, Department of Anesthesiology, SMC Vijayawada. I'm very grateful for sharing this prestigious platform, and I thank the organizing committee, especially Dr. Sukhminder sir, Madhuri madam, and all the other members of the ISA National for this wonderful opportunity. Thank you, one and all.
And Dr. Vinay is also a very, he was the one man behind all this, taking up the challenge and gearing up for this class actually.
Respected
So thank you, Dr. Vinay sir.
Respected professor and intensive care unit.
Yes, sir. So I think we can go ahead with the class, madam. Snehalata madam, you can start the PGs, moderate the PGs now.
Sir, I will introduce my PGs, sir.
Sir, already introduced. I think Rishita and Devi Brahmi have already been introduced. They can start the class now.
Okay, sir.
Yeah.
Content only. Okay, ma'am. Good evening, everyone. I am P. Rishita Reddy, second year postgraduate in Department of Anesthesiology, Siddhartha Medical College. I am grateful for my moderators and ISA for giving this opportunity, and I am honored to be here. my colleague Devi introduce.
Good evening, everyone. I am Dr. Devi Abhirami NS, second year postgraduate in Department of Anesthesiology, doing in Government Siddha Medical College, Vijayawada. I am honored and happy to present this presentation in front of the delegates and respected audience.
Slide మూవేనా అవర్లే Today I am presenting a case of peripartum cardiomyopathy. Moving to the case, a 28-year-old primary gravida from a 28-year-old multigravida, gravida 2, para 2 and live 1 from Nandigama was admitted to OBG department on 3/7/2025 at 37 weeks of gestation with shortness of breath and cough for 2 days, palpitation for 2 days and pedal edema for 1 week. History of present illness, she was apparently normal 1 week back and developed shortness of breath, cough and palpitation for last 2 days. History of breathlessness since 2 days of NIHA class 3. History of shortness of breath and supine position. It is relieved by sitting position. Her cough was productive and sputum was frothy. She developed edema in both legs from 1 week. No history of paroxysmal nocturnal dyspnea and hemoptysis is noted, and no history of chest pain. No history of syncope, headache, blurring of vision, and no history of fever, chills or rigors. Past history, she is not a known case of diabetes, hypertension, tuberculosis, CV or CAD, epilepsy and asthma. She is not on any medications. Family history, no relevant history. Personal history, she takes mixed diet, normal bowel and bladder habits, not a smoker and alcoholic, and there were no history of allergies. Antenatal history, previous NVD is uneventful, male child, last childbirth is 3 years ago. Present pregnancy, 2 TT doses taken, taking iron folic acid regularly. Regular antenatal checkups are attended. Her LMP was 3/10/2024 and expected date of delivery is 10/7/2025. Treatment history, she was on iron, vitamin B complex and calcium supplementation during her pregnancy. She was on regular antenatal checkup. Socioeconomic history, she belongs to low middle class family. General examination, patient is conscious, coherent and tachypneic, moderately built and nourished. No nutritional deficiencies were noted. Her height is 165 cm, weight 70 kg, BMI 25.7 kg per meter square. Edema present over feet and abdominal wall. No pallor, icterus, clubbing and lymphadenopathy. Her pulse rate is 120 beats per minute, regular, normal volume, no radioradial and radiofemoral delay. Blood pressure 90/70 mmHg in left arm sitting position. Respiratory rate 28 per minute. Saturation 85% on room air, improved to 97% on CPAP, and the patient is afebrile. Airway examination, no obvious facial deformity is noted. Bilateral nares patent, dentition normal, mouth opening is adequate. Cervical spine flexion and extension is normal. Modified Mallampati grade 2. Temporomandibular joint is normal. On systemic examination, respiratory system on inspection, chest is symmetrical, normal shape and movements, no scars, deformities, dilated veins or intercostal retractions are present. Trachea appears to be midline. On palpation, trachea midline, chest expansion equal bilaterally. On auscultation, bilateral basal crepitations are present. Cardiovascular system on inspection, precardium appears normal, no visible scars, dilated veins, no visible pulsations or abnormal movements. Apex bit not visible. Jugular venous distension present. On palpation, apex bit felt in left fifth intercostal space, midclavicular line. No thrills, heaves or parasternal lifts are present. Peripheral pulses are palpable, regular. On auscultation, S1, S2 heard, S3 present, apex bit felt in left fifth intercostal space. For abdominal examination, abdomen is symmetrically enlarged. Fundal height corresponds to gestational age. Fetal lie is longitudinal with cephalic presentation. Fetal heart is 140 per minute and regular. Investigations, blood grouping O positive, HB 9.8 mg per deciliter, total leukocyte count 10,000 cells per microliter, platelets 1.5 lakhs, viral markers non-reactive, serum bilirubin 0.5 mg per deciliter, serum creatinine 0.5 milligram per deciliter, serum electrolytes, sodium 138, potassium 4, chloride 102, her FBS is 103, bleeding and clotting times were normal, coagulation profile, prothrombin time 11 seconds, INR 0.8, urine proteins are negative, and we have advised for ABG also. In ECG, sinus tachycardia and features suggestive of left ventricular hypertrophy is present. Ultrasound was gravid, containing single live fetus with regular cardiac pulsations and normal fetal movement. Fetal presentation is cephalic, placental, fundal and posterior in position and away from os. Gestation is estimated to be 37 plus weeks. Echocardiography was performed, which showed global hypokinesia with moderate to severe LV systolic dysfunction, ejection fraction of 38%, borderline left atrium and left ventricular dilatation is seen, mild to moderate mitral regurgitation and mild tricuspid regurgitation were noted. Cardiologist opinion was taken and diagnosed the case as peripartum cardiomyopathy. Coming to case summary, a 28-year-old multigravida of 37 plus weeks gestation admitted to GGH Vijayawada with sudden onset of shortness of breath, productive cough and palpitation for 2 days, which aggravated by walking and relieved by taking rest. She was dyspneic and peripheral edema was present in both the legs. Her pulse rate was 120 beats per minute, blood pressure 90 by 70 mmHg and respiratory rate was 28 beats per minute. On systemic examination, JVP found rise and there was bilateral basal crepitations present. Provisional diagnosis, primary with 37 weeks of pregnancy, query suggestive of peripartum cardiomyopathy. Yes, ma'am. Multigravida with 37 weeks of pregnancy. Yes, ma'am. Yes, ma'am. Ma'am, peripartum cardiomyopathy, it is an idiopathic condition defined as cardiomyopathy in the last month of pregnancy or first 5 months postpartum in a woman without previous cardiac disease and after excluding other causes of heart failure. It is a diagnosis of exclusion. Diagnostic criteria include classic criteria, onset of heart failure between 36 weeks of pregnancy and first 5 months postpartum, no evidence of heart disease prepartum, and no other causes of heart failure. Additional criteria in 2D echo include left ventricular systolic dysfunction with left ventricular ejection fraction less than 45%, left ventricular fractional shortening less than 30%, and left ventricular end diastolic diameter greater than 2.7 centimeter per meter square body surface area.
Excuse me. The questions of the faculty are not audible. The faculty voice is not heard. Yeah. We cannot hear you, ma'am. Srilata, ma'am, we can't hear you. Please check your system. Check your system, ma'am. Snehalata, ma'am, you please take over till madam checks her system.
Am I audible, ma'am?
Yes,
Am
you're
I
audible,
audible?
ma'am. You please take over till madam checks her system. What's wrong?
So Rishita,
Ma'am,
what are the risk factors associated with peripartum cardiomyopathy?
ma'am, mainly the risk factors associated with peripartum cardiomyopathy are advanced maternal age greater than 30 years, multiparity, multiple gestation, obesity, African ethnicity, previous history of peripartum cardiomyopathy, pregnancy associated hypertensive disorders, long-term tocolytic therapy with beta agonist, artificial reproductive technologies, nutritional deficiencies like selenium and zinc, family history of peripartum cardiomyopathy, or if there is a sudden cardiac death in the family.
What is the global incidence?
Globally, it is reported to be between 1 by 1000 and 1 by 4000 live births. In Nigeria, it is reported to be 1:100, and Haiti 1:300. Recently, there has been an increased trend in United States of 1 by 3000 live births. In Japan, it is reported to be 1 by 6000 live births. Overall, the incidence is more in the African black populations, and there is a recent trend in increase in the white populations.
What might be the reason? Because of low socioeconomic status and the customs.
Yes.
Okay.
Okay, ma'am.
So, Devi,
Yes, ma'am.
what are the etiological factors and what is the pathophysiology of this condition?
The exact etiology of peripartum cardiomyopathy is not known, which is idiopathic, and however, it is believed to be multifactorial, contributed by several factors that includes oxidative stress, genetic predisposition, abnormal immune responses, and hormonal factors. First, coming to genetic predisposition, due to the single gene mutation involved in the titin gene and also ADRB1 gene, which is adrenoreceptor 1 gene, have been identified, and they have been linked to the hereditary responsibility of this disease. And coming to oxidative stress, due to oxidative stress, there is cleavage of the prolactin forming 16 kDa prolactin fragment, which is an apoptotic fragment and which causes apoptosis, cardiac dysfunction, and downregulation of the cardiac protection in the cardiac myocyte, and also abnormal immune responses that includes in the fetal cells get lodged in the maternal cardiac tissue. After delivery, they are recognized as non-self and autoantibodies are produced against them, and hence this pathogenesis is initiated.
What are the signs and symptoms?
Commonly, they present with the signs of dyspnea, dyspnea on exertion, orthopnea, PND, fatigue, weakness, cough, palpitations, and peripheral edema. Less commonly, in severe cases, they may present with hemoptysis, syncope, lightheadedness, excessive weight gain during the end of pregnancy, and frequent nocturnal urination. And the signs include tachycardia, tachypnea, use of accessory muscle during respiration, displaced apical impulse in previous examination, and also jugular venous distension can be present. On auscultation, we can hear scale and mitral regurgitation function. On respiratory system examination, we can get violent palpitations and diffuse dull sounds because of pleural effusion.
See, it has been called as a diagnosis of exclusion. So, what are the differential diagnosis?
Peripartum cardiomyopathy is called as diagnosis of exclusion because the diagnosis of PPCM is made only after ruling out other potentiating causes of heart failure after investigating it. When asked about differential diagnosis, it includes pulmonary embolism, amniotic fluid embolism, severe anemia, severe sepsis, myocardial infarction, viral myocarditis, dilated cardiomyopathy of other etiologies, and arrhythmias pre-eclampsia also. MCQ 1, ma'am.
Yeah, please display the MCQ.
Display this. Show. MCQ.
Yeah, please read out the MCQs and
Yeah.
can you widen the
Yeah, ma'am.
screen, please, Dr. Rishita?
Okay, ma'am. Peripartum cardiomyopathy is considered a diagnosis of exclusion. In which of the following conditions would exclude a diagnosis of PPCM? A. Heart failure developing in the last month of pregnancy. B. Echocardiographic evidence of left ventricular ejection fraction of 40%. C. Recognizable heart disease symptoms in the first trimester. D. Elevated brain narcotic levels. Question to the audience.
Yeah, give them some time. Your voices are echoing. There's some problem with your voice.
Dr. Virendra has answered this question with D, elevated brain natriuretic peptide levels. Everyone else is also encouraged to please answer the question. Dr. Ruchi has answered C, Dr. Smita B, Dr. Vamshi C, Dr. Rajgopalan C, Dr. Amar C, Dr. Kiranjit C, Dr. Chandana C. Ma'am, can you please answer the question? Dr.
So
Rishita?
the answer is C, because heart failure developing in the last month of pregnancy is one of the diagnostic criteria, and also ejection fraction less than 45% is also one of the diagnostic criteria, and elevation of the brain natriuretic peptide is one more diagnostic criteria, but it is recognizable heart symptoms in the first trimester is the answer, because it is a disease presenting in the last trimester of pregnancy and immediate postpartum. So answer is C.
Second MCQ for the audience, ma'am.
Right.
Can you please widen the screen and go ahead?
1 minute, ma'am.
Second question.
Okay, ma'am.
Second MCQ for the audience, ma'am. A 38-year-old African American woman who has had 3 previous pregnancies is suspected of having PPCM. Which among the following is not explicitly identified as a specific risk factor for PPCM? Option A, her advanced maternal age over 30 years. Option B, her African American ethnicity making her 3 to 5 times more vulnerable. Option C, her history of 3 previous pregnancies, which is multiparity. And option D, a personal history of chronic non-pregnancy induced hypertension.
You have an enthusiastic audience today. People have started answering this MCQ. Dr. Geeta has answered D, Dr. Vamshi D, Dr. Ritin, Dr. Ruchi has answered A, Dr. Bashiruddin has answered it as D, Dr. Sakshi is also saying D. Ma'am, can you please answer the question?
Ma'am, unmute yourself. Snehalata, ma'am, please unmute yourself.
Yeah, ma'am. So it is a disease of the advanced maternal age, mainly affecting the African American ethnicity with multiple pregnancies and also with a multiparity. So a personal history of it is most commonly accompanied by pregnancy-induced hypertensive disorders. It is commonly associated with pregnancy-induced hypertensive disorders. So the answer is D. There is no association between non-pregnancy induced hypertension.
Thank you, ma'am. Can we move on to the next question?
Next, coming to investigations.
Yes, ma'am.
Is it audible, madam?
Yes, very clear now. Please go ahead.
Yes,
So
ma'am.
now we will start with investigations. So what are the specific investigations in this case? You want, Rishita?
Ma'am, the primary diagnostic investigations are ECG in this patient, which is showing sinus tachycardia and features of left ventricular hypertrophy. 2D echo is the confirmatory test. It demonstrates left ventricular ejection fraction less than 45%, and there will be enlargement of all four chambers, especially left atrium and left ventricle. Global hypokinesia of the left ventricle may be seen, and there will be mitral or tricuspid regurgitation. 2D echo is also used to monitor treatment effectiveness and 2D effectiveness and brain natriuretic peptide levels. It is used for diagnosing and used to monitor severity of peripartum cardiomyopathy. In chest radiography, there may be cardiomegaly or future suggestive of pulmonary edema. We advanced our transesophageal echocardiography for left to precisely determine left ventricular ejection fraction and cardiac MRI to evaluate myocardial viability and coronary angiography to rule out MI, and we do cardiac biopsy to rule out any inflammatory conditions.
Among all these investigations, the gold standard is TEA, transesophageal echography is the gold standard for diagnosis of peripartum cardiomyopathy. Then coming before going to surgery, so what are the pharmacological, medicative drugs you want to give this to optimize before taking to surgery?
Ma'am, the general principles of medical management, similar to other causes of heart failure, we have to maintain adequate oxygenation, fluid and salt restriction, ventricular offloading by diuresis and vasodilation. We have to maintain preload and reduce afterload, increase myocardial contraction force, and we have to stabilize hemodynamics. The agents which are safe during pregnancy are loop diuretics, furosemide, 10 to 20 mg. It will reduce pulmonary congestion and peripheral edema. Digoxin, it is also considered safe in pregnancy as it provides positive inotropic effect. Beta-1 selective beta blockers, metoprolol, bisoprolol, they are indicated to improve survival and should be used after signs and symptoms of heart failure have begun to improve. Vasodilators, which are safe for hydrogen and nitrates, as they are reducing the afterload, preload, and intracardiac filling pressures, ma'am.
So what are the usually contraindicated drugs in this case?
Ma'am, generally contraindicated drugs in pregnancy are AC inhibitors and ARBs, as they are associated with increased fetal loss, fetal renal dysfunction, and oligohydramnios. By breastfeeding also, they are contraindicated. Postpartum, they are the first-line therapy to improve mortality and cardiac remodeling. Calcium channel blockers, they are contraindicated because of their negative inotropic effect. Aldosterone antagonist, spironolactone, because of anti-androgen effect, and the ergometry and carboprost also contraindicated as they increase the afterload. Nitrous oxide is contraindicated because it increases the pulmonary vascular resistance. In these patients, as they are more prone for thromboembolic events, we prefer prophylactic anticoagulation, and the low molecular weight heparin is preferred during pregnancy. Warfarin is contraindicated because of teratogenicity. Low dose aspirin, 75 to 100 mg per day, may be given to all pregnant women for mechanical valves, and the anticoagulation must be discontinued before pregnancy and before insertion of epidural catheter to avoid neurological complications.
By summarizing this, so this, even though AC inhibitors are contraindicated, but once the delivery is over, that is, then in postpartum period, if there is associated LV dysfunction, then AC inhibitors can be used.
Yes,
so
ma'am.
this is the important point. Okay.
Okay, ma'am.
Okay. Devi, what are the various non-pharmacological interventions and advanced mechanical support devices used in severe PPCM?
Coming to the non-pharmacological interventions, mainly three things to be taken care of. Firstly is oxygenation, secondly is hemodynamic stability, and third is advanced mechanical support. When oxygenation, it can be given either by
Dr. Devi, you're not audible properly.
You done.
You can take up. Dr. Ishita, you can take up that answer till she settles down. Yeah. Take up that answer till she settles down. Yeah.
Mainly,
The non-pharmacological interventions is mainly focused on three things. One thing, oxygenation, second, hemodynamic stability, and third is mechanical support. So when coming to the oxygenation, it can be given either by non-invasive ventilation, or if not maintaining, we can go for invasive mechanical ventilation. And in case of hemodynamic stability, it can be given by inotropic support. The inotropic support includes dopamine, dopamine, levosimendan, milrinone, etc. In case of advanced mechanical support, it can be given either by intra-aortic balloon pump, which can be used in severe cardiogenic shock, left ventricular assist devices in case of severe cardiac failure, and ECMO can be used in case of cardiac and respiratory failure, and also heart transplantation is the preferred choice in case of refractory cases of managing PPCM. And there is a role of implantable defibrillators and cardiac resynchronization also. It can be used in the women who survive the acute phase, but with ongoing significant functional impairment.
So, what are the anesthetic goals in perioperatic cardiomyopathy?
The primary anesthetic goals include maintaining hemodynamic stability, optimize the cardiac output, maintain the preload, avoid increase in afterload, avoid tachycardia, hypotension, and avoid use of myocardial depressant drugs, ensure fetal well-being, and pre-plan for labor and delivery, and also the postpartum care, and maintain or increase the myocardial contractility.
So, how will you how will you optimize the patient preoperatively?
First, we have to get the early consultation from the concerned obstetrician for delivery. Second, we have to get a cardiologist opinion for the management of congestive cardiac failure and optimize the congestive cardiac failure at least a week before a planned surgery and continue beta blockers and maintain hydration. Proper preloading of the patient is important to maintain volume expansion to prevent hypotension in case of induction, and also proper pre-medication of the patient is important to alleviate the anxiety and also to decrease the sympathetic stimulation during anesthesia, and also identify for any contraindications to neuraxial anesthesia. There's an MCQ for the audience. Yes.
Ishita, you can do that.
Ishita, you can read out.
You can read.
okay, ma'am.
You read out.
Ma'am, which of the following agents is contraindicated in a case of peripartum cardiomyopathy during pregnancy, primarily due to teratogenic effects and potential for fetal renal dysfunction? Option A is hydralazine, used to reduce afterload and preload, metoprolol tartrate, a beta-1 selective beta blocker. Option C is angiotensin converting enzyme inhibitors, which improve mortality and cardiac failure. Option D is furosemide, a loop diuretic to reduce pulmonary congestion. Which of the following had the teratogenic effects and contraindicated during pregnancy, ma'am, especially for fetal renal dysfunction?
The audience has all started answering. Dr. Arnav says C, Dr. Hemang says C, Dr. Vamshi says C, Dr. Smita says C, Dr. Ruchi has answered with A, Dr. Sakshi, Dr. Kiranji, Dr. Virendra have answered with C, and Dr. Bhava Harini have answered with A. Ma'am, Snelata ma'am, can you please answer the question?
So this is, I have already told that AC inhibitors are contraindicated during pregnancy, but once it is postpartum, then we can give. So answer is C.
Okay, ma'am. Ma'am, there's a question related to this from the audience, Dr. Muthu Kumar. Can ACE inhibitors be given during breastfeeding? Are they safe?
During this, we can give.
Okay, ma'am. And he has also asked if bromocriptine, that is a prolactin antagonist, is it useful in peripartum cardiomyopathy?
So the etiology factors are more, whether it may be immunological or prolactin, we can't say unless it is diagnosed. So we can give safely this drug. So etiology, one of the etiology may or may not. Prolactin may or may not the etiological factor, then we can give this safely during lactation also.
Okay, thank you, ma'am. Ma'am, next question, please, from you.
Next is Rishita, what is the mode of delivery and consideration regarding this case?
Ma'am, first the decision for mode of delivery is based on obstetric history, current hemodynamic status of the patient, and whether she is responding to medical management or not. Mode of delivery, vaginal delivery is preferred if there are any no obstetric regions for cesarean section, and if she is having compensated peripartum cardiomyopathy. And cesarean section is reserved for patients with a decompensated heart failure, and there are absolute indications for cesarean section. We prefer urgent delivery if the patient is hemodynamically unstable despite the medical management, ma'am.
So you mean the delivery, vaginal delivery is safe if it is normal, mild to moderate case.
Yes,
So is there any chance of any indication of painless labor before going to vaginal delivery or any contraindication?
Ma'am, in mild to moderate cases of as the patient is a cardiac disease, we prefer labor analgesia, ma'am. As the labor analgesia, by giving analgesic doses, the catecholamine surge is decreased, and the cardiovascular stress and systemic vascular resistance, and also it reduces the afterload. It reduces the painful stimuli caused by contractions. So we prefer analgesia during labor, during phase of labor, ma'am. And preferred drug is ropivacaine due to its cardiac stability, and also it preserves motor activity. It preserves the pelvic muscle tone and facilitates the internal rotation of the fetus and normal vaginal delivery, ma'am.
So you mean labor analgesia? What roles are? So whenever there is pain, there is increased secretion of catecholamines, which will increase the hypertension in the mother. So that vasoconstriction will also cause fetal placental insufficiency, less circulation to the baby. That's why by advising this labor analgesia, both mother and baby is also benefited. Okay. And also coming to these agents, we can use bupivacaine or ropivacaine. But during 14 and 15, our postgraduate have studied this painless labor in comparison with ropivacaine and bupivacaine, where the conclusion is when you use the ropivacaine, so it is more sensory. That's why so motor is less. So for normal vaginal delivery, internal rotation is very important at levator and emergence. So if we use painless labor with ropivacaine, so the instrumental deliveries are less. So the conclusion is when we have used this ropivacaine as a painless labor, so the patients are going for vaginal delivery, whereas in ropivacaine cases there may be some instrumental and means outlet forces may be required. So this is the inference during our study. So next, coming to what are the advantages of regional anesthesia and general anesthesia? Advantages, disadvantages.
Okay. Regional anesthesia is preferred, ma'am, due to hemodynamic stability. It helps maintain the blood pressure levels. It reduces preload, afterload due to sympathetic blockade, improving the cardiac output, and also it decreases the sympathetic tone. It provides adequate analgesia and anesthesia. It minimizes the incidence of venous stasis emboli, and also it avoids the cardiovascular and respiratory depressant effects of general anesthesia drugs, ma'am.
So what are the techniques of regional anesthesia? Various techniques. That means the spinal or epidural or combined. So which is advantages of this technique?
Ma'am, by giving spinal anesthesia, there is sudden hemodynamic changes will be there. Hypotension will be occur. We prefer mostly epidural anesthesia by titrated doses. Local anesthetic like ropivacaine with fentanyl 50 mics, ropivacaine 0.7% are used in boluses, ma'am, of 3 to 4 ml. Ropivacaine is preferred as it is cardiac stable. We ensures a slow and gradual reduction in afterload, and which provides effective post-operative analgesia also. In combined spinal epidural also, there is rapid onset of spinal anesthesia, and we can also extend the titrate and extend the duration through epidural catheter we inserted, ma'am.
Devi, what are the various techniques of labor analgesia and what are the pain pathways involved? And can you mention a few more advantages of labor analgesia?
Yes, ma'am. When talking about labor analgesia, there are different pain pathways involved here in different stages of labor. The first stage of labor, the pain is due to the uterine contraction and cervical dilatation, and the pain impulses are traveled through the hypogastric plexus and reaches the spinal cord at the level of T10 to L1. And in the second stage of labor, the pain is due to the distension of the perineum, and here the pudendal nerve carries the impulses to the spinal cord at the level of S2 to S4. These are the pain pathways involved in the labor analgesia, ma'am. Coming to the advantages of labor analgesia in pregnant women, early labor analgesia is important. Usually it is given when cervical dilatation is 4 centimeters. It reduces the sympathetic response caused by the painful contraction. It decreases the afterload. It decreases the catecholamine surge. It also decreases the systemic vascular resistance and thereby decreasing the myocardial workload. And also it is helpful in case of surgical anesthesia if required. The patient is posted for any emergency cesarean section. Also, the drugs administered here are the local anesthetics in titrated doses like ropivacaine and bupivacaine. The various techniques associated with the labor analgesia can be non-pharmacological and pharmacological. The non-pharmacological techniques include simple relaxation therapy, breathing exercises, acupuncture, massage, hypnosis, aromatherapy, music therapy, etc. And the pharmacological includes, it can be different types, that either it is regional or systemic. Regional by epidural and systemic is by inhalational or parenteral. Inhalational is generally by Entinox, which is 50% oxygen with 50% nitrous, or CVOX, which is 0.8% sevoflurane with oxygen. And parenterally, it can be given by opioids that includes fentanyl, remifentanil, nalbuphine, pethidine, etc. Here, the analgesia is administered by patient-controlled analgesic infusions, and in epidural, it can be given by PCEA, which is patient-controlled epidural analgesia.
So, what are the indications of general anesthesia and what are the risks also? Indications and risks of general anesthesia.
The indications of general anesthesia are actually, it is reserved only for emergency cases, and it is also indicated when only when the regional anesthesia is contraindicated or there is any failed regional anesthetic procedure. And also it is preferred in cases of in case in which the patient is on anticoagulant therapy. Also, this is the preferred mode of choice in acute severe PPCM cases and also in patients with decompensated heart failure, ma'am. The risks associated include higher risk of cardiovascular incidents like arrhythmias, hemodynamic instability like hypotension are more prone in general anesthesia. And there is also a risk of aspiration, stressor response during intubation in a cardiac compromised patient. And also myocardial depression effects of intravenous and volatile anesthetics can also occur. And avoid using induction agents that are myocardial depressant like propofol and thiopentone sodium. And also avoid using benzodiazepines and nitrous oxide, which can cause severe cardiovascular decompression. And avoid using the drugs that increases the heart rate and contractility, including atropine, epinephrine, and ephedrine.
There is a MCQ for the audience.
A pregnant woman receiving low molecular weight heparin has just had her epidural catheter removed. Which of the following statement is correct regarding the management of her anticoagulation? Option A, the next LMWH dose can be given immediately after the catheter is removed. Option B, the epidural catheter can be removed at any time after the last LMWH dose. Option C, the next low molecular weight heparin dose should be delayed for at least 4 hours after the catheter removal. Option D, anticoagulation should be restarted within 12 hours of delivery, regardless of the delivery method.
Few people have answered the question. Dr. Anup says D, Dr. Virendra D, Dr. Shandana D, Dr. Ruchi, Dr. Sakshi C, Dr. Gautam C, Dr. Kiranjit C, Dr. Anil D. Ma'am, may I request you to please answer the question?
Yes. For low molecular weight heparin, it should be stopped. If it is a prophylactic dose, it should be stopped 12 hours before proceeding for neuraxial anesthesia. And if it is a therapeutic dose, it should be stopped 24 hours before proceeding for the neuraxial anesthesia procedure. And the catheter, after removal of the catheter or the procedure, the catheter can be again, the low molecular weight heparin can be again restarted after 4 hours for both prophylactic and therapeutic dose. So here the 4 hours should be delayed for at least 4 hours is the correct answer. C is the correct answer.
Thank you so much, ma'am. From next MCQ. Meanwhile, ma'am, we have a question from the audience. Dr. Muthukumar has asked, how do we manage anticoagulants in these patients with LV clots? Please unmute your.
Usually these LV clots, the source of these clots usually we deal with pulmonary ablation, and also usually the source of these clots is from the pulmonary vein. They are the cause of the atrial fibrillation and all. So for an atrial, if it develops, we can as well go with the rate control. We can done with can be done with beta blockers, calcium channel blockers, and also digoxin can be used. If we want to control the rhythm, we can go with if the patient is stable, we can go with amiodarone, or pharmacological cardioversion, we can go with flecainamide. Or we can, if the case is unstable, we can go with DC cardioversion synchronization.
Okay, thank you, ma'am. We can proceed with the session.
Then, what are the basic monitors and used in this case while surgery is going on? What are the basic standard monitors and also invasive monitors? Rishita.
Ma'am, the basic monitors include continuous ECG to detect arrhythmias and STT changes. We have to strictly monitor oxygen saturation and non-invasive blood pressure with frequent measurements, waveform capnography monitoring. In addition to standard monitoring, invasive modalities are invasive arterial blood pressure monitoring for real-time beat-to-beat measurement of blood pressure, central venous catheter to guide the fluid administration, for safe administration of vasoactive drugs and inotropes, ma'am. pulmonary artery catheter for a precise measurement of pulmonary artery pressures, cardiac output, and mixed venous oxygen saturation. We can also do cardiac output monitoring for the judicious use of vasopressors and inotropes and transesophageal echocardiography for the to know the precise volume status and for the effect for assessment response to our interventions.
So coming to the actual case, so this case is presented to labor room, multi with 37 weeks pregnancy, and came to the labor room with a complaint of, already she told that breathlessness and palpitation. So after while we are recording, the patient suddenly desaturation is 85% oxygenation. Then we have put this CPAP, then increase. So still it is unstable. So we have intubated the patient at labor room itself. So the gynecology obstetrician, she wants to do emergency cesarean section for this case. So they want to shift the case to surgery. So how will you manage this emergency cesarean section? You are there at the theater, Rishita.
Ma'am, actually this we intubated the case at at labor room, ma'am. After that, as obstetrician indicated, we shifted the patient to emergency OT. After we have taken the high risk video consent of the from attenders. After shifting the patient to OT, we as usual connected the standard monitors like pulse oximetry, ECG and NIBP and capnography. And right subclavian catheterization is done. As the patient is already intubated, we pre-medicated the patient with injection ondansetron 4 mg, glycopyrrolate 0.2 mg, and fentanyl 30 mcg was given. And we induced the patient with etomidate 14 mg, and the patient is paralyzed with vecuronium 4 mg. During the surgery, the patient was maintained on oxygen, sevoflurane, and vecuronium on incremental doses. Throughout the surgery, the patient has stable vitals. Urine output monitoring was also done. After the delivery, 10 units of oxytocin was given in 200 ml NS. In 200 ml NS, vitals were stable throughout the surgery. For post-operative analgesia, we have given a bilateral tab block, and after the completion of the surgery, we have shifted the patient to ICU for elective ventilation and for monitoring of the patient. After shifting the patient to ICU, we have connected her to basic monitoring like ECG, pulse oximetry, NIBP, and the CVP is also there. We put the patient on pressure mode ventilation of P inspiratory 16 centimeter of water with respiratory rate 14 and FiO2 1 with PEEP 7 centimeter of water. After thorough monitoring was done in ICU, ma'am.
For the sake of summarizing, so the patient was shifted to theater for emergency LSCs. So while patient is taken into the theater, the BP is 90 by 90, mean between 90 to 80. So we have cannulated the subclavian end because there is a patient is already in hypo. So we have connected to inotropes like NOR and dobutamine. So to avoid this fluid by giving only crystalloids. So, and also how will you manage this fluid management during the surgery, throughout the surgery?
Ma'am, we have checked for blood loss and we have replaced the blood loss promptly and meticulously. CVP guided fluid administration was done by urine output monitoring. We have avoided excessive crystallites as it may contribute to pulmonary edema. Strict fluid balance is taken to prevent both overhydration and hypovolemia. Overhydration and hypovolemia.
So the complication during surgery may be pulmonary edema and arrhythmias and even cardiac failure. Immediately after delivery of the baby at placenta, there may be more of fluid incoming. So it may itself cause pulmonary edema. That's why we have given inotropes through central line, and also titrated the fluid to avoid this excessive fluid to prevent pulmonary edema. Then we have maintained post-operative pain management with bilateral tablet. So as the patient is already unstable, so better to have this regional anesthesia. That's why we have given. And the patient is having lungs are basal crepitations. So that's why we have thought that pressure ventilation is better in this case. We have connected the pressure ventilator mode in ICU. Over to Snehalata.
1 minute. MCQ.
Okay, you can displace that MCQ.
Okay, ma'am. MCQ 5, ma'am. In the severe PPCM cases, what is the specific primary role of extracorporeal membrane oxygenation device? Option A, to augment coronary blood flow and minimize embolization risk in critically ill patients. Option B, to provide long-term support for cardiac contractility until heart transplantation becomes feasible. Option C, to provide both hemodynamic support and gas exchange in cases of severe cardiac and respiratory failure. Option D, to deliver electrical shocks to prevent sudden arrhythmic death.
So the answer is C. It provides both hemodynamic support and gas exchange in cases of severe cardiac and respiratory failure. Okay. Devi, what are the factors that decide the better and poor prognostic outcomes?
The overall mortality globally and the recovery rate globally first we'll see. Overall mortality in globally is 0 to 19%, and which is high to 25 to 50% in the first 3 months postpartum, and it is reported very high in Africa and in Haiti as mentioned previously, which is up to 30%. When coming to the rate of recovery, it is approximately 30 to 50% only when the left ventricular ejection fraction is more than 50%. When coming to the question as such, the factors associated with poor prognosis and good prognosis. First, poor prognosis, when it is a delayed diagnosis or a high NYHA grade at the time of presentation and severe LV impairment when LV ejection fraction is less than 30% and LV fractional shortening less than 20% and LV end diastolic diameter more than 6 centimeter at the time of presentation. Also, when there is persistent cardiomegaly and QRS complex in the ECG, which is greater than 120 milliseconds, multiparity, African descent, and also blood investigation showing high troponin levels and also high pro-BNP levels. When pro-BNP levels more than 1860 picograms per ml, then it is more towards the bad prognosis side. When talking about good prognosis, it includes small left ventricular end diastolic volume, which is less than 5.5 centimeters, and left ventricular ejection fraction greater than 30%, between 30 to 35%, and even good if it is more than 50%, and fractional shortening more than 20%. And when there is absence of troponin elevation and also absence of any LV thrombus, and in case of non-African ethnicity, there is good prognosis in cases.
What are the various complications associated?
The various complications associated in general with the PPCM cases includes thromboembolism, arrhythmias, which may include supraventricular tachycardia, atrial fibrillation, atrial flutter, progressive heart failure, cardiogenic shock, pulmonary edema, or it can be a misdiagnosis, particularly as preeclampsia, which has overlapping symptoms.
How will you manage this case in ICU?
Continuous hemodynamic monitoring with non-invasive and invasive monitoring parameters, if available, is very good. and strict meticulous fluid management should be done, avoiding overhydration, and also pain management. Adequate pain management is very important in these cases, which can be given either by systemic IV opioids, by patient controlled analgesia, or by giving bilateral tap blocks as in our case. And also we can give it by epidural catheter if present, by epidural analgesia, by giving low doses of titrated doses of ropivacaine, which is cardiac stable drug. When telling about the ventilatory settings in the ICU, we can give the ventilatory settings with lung protective strategies that includes a low tidal volume, higher respiratory rate, and less plateau pressure, which is less than 28 centimeters of water. And the judicious use of PEEP is very essential in case of PPCM to maintain oxygenation. Also, target PaCO2 should be maintained between 40 to 45 mmHg, and pH should be maintained between 7.25 to 7.35. And we have to keenly monitor for any complications that may occur in ICU. That includes arrhythmia, hypotension, pulmonary edema, sudden cardiac death, thromboembolism, etc. In case of pulmonary edema, then it should be managed by giving Lasix, morphine, nitrates, proper oxygenation of the patient, and setting up posture of the patient also helps in better oxygenation. And early detection of water retention should be taken care, as oxytocin given after the delivery of the baby can have water retention effects due to the antidiuretic effect of this hormone. And also, or reabsorption of the third space fluid after C-section should also be taken care of. Maintaining normoxia, normocorbia, normotension, and normothermia is important in the ICU. Also, appropriate thromboprophylaxis, cardiac monitoring, and electrolyte balance should be taken care of.
Can you give spironolactone for these cases?
Spironolactone is generally contraindicated, ma'am, as it has myocardial depressant, anti-androgenic effects.
So, what advice you want to give for these females, that is post preconceptional counseling?
If a case of PPCM has been presented to us, we have to advise them against the future pregnancies because there is high chance of recurrence. So better ask them to get non-estrogenic contraception done, or better to go for sterilization methods.
David, so what is the outcome of this patient in ICU? So how we have followed this case in ICU? How will we manage this?
We did a continuous hemodynamic monitoring of the patient, ma'am, along with serial echoes were done for cardiac evaluation and to check for any progression of the disease. Also, meticulous fluid management we ensured, strictly avoiding overhydration, ma'am. And also, ventilatory support was continued with lung protective strategies that, as we have mentioned earlier, with the low tidal volume, high respiratory rate, and low plateau pressure. And also, we monitored with whatever basic monitors possible with invasive and non-invasive modalities. Furosemide 10 mg BD was continued, and patient was keenly monitored for any complications like arrhythmias, thromboembolism, pulmonary edema, and any progression of heart failure and cardiogenic shock. Serial ABGs we took, ma'am, and we repeated CBP and serum electrolyte, and chest X-ray also was done. We gradually tapered the supports, inotropic supports, and we extubated the patient once the ABG was within normal limit. Patient post extubation, patient was hemodynamically stable, conscious, and coherent, ma'am. After stabilizing the patient, we observed her in the ICU for 24 hours just to ensure the patient doesn't require any re-intubation, keeping up the intubation kit ready. But since she was all fine, after 24 hours, she was stepped down to post-operative ward, ma'am. After 1 week of follow-up, after uneven full recovery, she was discharged from the hospital.
Rishita, so what are the various parameters you will take care in this patient while patient is on ventilator? So what is the care of the patient during ventilation?
Ma'am,
to prevent ICU infections and sepsis in ICU patients. We took care of mouth by chlorhexidine mouthwashes, and eye care. Eye should be taken care. Closed suctioning for 2 hours, which is connected to a ventilator, and DVT prophylaxis by compression stockings and low molecular or unfractionated heparin should be done. Anti-aspiration prophylaxis by proton pump inhibitor or H2 receptor blockers should be done. And urinary bladder care should be taken. Central venous catheter care also be taken. Not keeping it open to air. And if there is soakage, frequent removal of dressings should be taken care of to prevent sepsis in patients, ma'am.
So
Chest
what are
physiotherapy should also
what are
be
the
done.
weaning modes? So she told that we have weaned when there is hemodynamic. So how will you, what are the weaning modes? So first you have given put on pressure control. Then how will you wean off this patient?
Then we keep from pressure control, we shifted the patient to SIME mode, ma'am. From there to pressure support ventilation, from there to CPAP, and we kept the patient on TP style for 2 hours. And after that, we have sent the ABG, ma'am. All parameters in ABG is normal. After that, we have decided to extubate the patient, ma'am.
Suppose so patient was shifted to emergency LSCs, is it not?
Yes,
so
ma'am.
we have given central line and have maintained inotropes, everything is have done. But somehow patient is not recovered. So patient went into arrest. How will you manage this case?
Ma'am, if she will land in a sudden cardiac arrest, we should first call for help and to inform the obstetrician and pediatrician for help also, ma'am. In this case, as she is in gravid, manual uterine tilt to left is taken. Manual uterine to left is indicated, and we have to do effective cardiopulmonary resuscitation. And if there is asystole or pulseless electrical activity, adrenaline should be administered. Timely defibrillation is indicated. It is also safe in pregnancy. We have to maintain airway and ventilation with 100% oxygen and with the waveform capnography. And if there is no return of spontaneous circulation, emergency hysterotomy is indicated if she is greater than or equal to 20 weeks, ma'am.
So the difference between CPR while for normal patient while you are doing CPR in pregnant patient. So while in normal patient we have keep the patient our hand, both locked hands and lower half of the chest, whereas if it is a case of partrident patient pregnancy arrested, so we have to keep on the lower half.
Yes,
so
ma'am.
just about that, and also you have to see that recoil should be there. Otherwise, if you are not allowing complete, so you are compressing on empty heart, it is no use. Okay. So that's why this is hysterotomy is not the word, but with the help of obstetrician and pediatrics, so as early as possible, within 5 minutes, you have to deliver the baby. So that is peripartum cesarean section. Okay, that is called peripartum cesarean section. So in order to avoid decrease the IMR, and also the mother may be, because of this evacuation of the fetus, the mother may recover. So to decrease IMR and also MMR, so we have to ask this obstetrician for peripartum cesarean section. Is it not?
Yes, ma'am.
So in this situation, I would like to share my experience with this peripartum cesarean section. So while I am doing at Kurnool, so say a call from labor room, so patient is not doing well. So while we are ready to go, so the patient is shifted to the theater because of patient is already arrested. So by the time the patient entered into the theater, I mean in the before entry to the OT itself, patient is arrested. So we have maintained high quality CPR and continued oxygenation. Or we have shifted to the theater. So the obstetrician has done cesarean section. So the baby is alive. So this is peripartum cesarean section. Another case is, so recently 10 days back, some 20 weeks pregnant patient. So, 34 weeks pregnant patient was referred from Machilipatnam Medical College. So by the time the patient reached, it's already brain death. So there is no pupils are already dilated, no reaction fixed. So already patient is on inotropes, and also they told that already brain death. So anyhow, was referred to our GGH Vijayawada. So as there is fetal heart, so obstetrician want to do cesarean section in sake of to save the infant baby. So the cesarean section was done. So baby is little cry, but with oxygen support and CPAP, baby is doing well. But we couldn't. Baby mother is already brain dead. So we have counseled the husband. So whether to continue ventilation or not. So according to the decision of husband, so we continued the ventilation support for 5 days. On 6th day, mother was expired, but baby is alive. So the role of peripartum cesarean section is, so we can decrease the IMR and maternal mortality.
Last MCQ, ma'am. For the audience. What is the most common advice given to women with PPCM who have persistent cardiac dysfunction and are considering subsequent pregnancies? Option A, subsequent pregnancies are generally encouraged with close monitoring. Option B, pregnancy is often associated with relapse and high risk of maternal morbidity and mortality, so it should be discouraged. Option C, genetic counseling alone is sufficient to manage the risk of future pregnancies. Option D, only non-estrogen methods of contraception are absolutely contraindicated.
So for this question, we have the answers from the audience. Dr. Anbu Gauthaman, Dr. Sakshi, Dr. Kiranji, everybody has answered B. Dr. Shiva Kumar, Dr. Kanoj, Dr. Ruchi, Dr. Bhavharini, everybody is answering with B. Ma'am, may I please request you to answer the question?
So B is the correct answer. So patient is already on relapse means, so the 80% chances of getting peripartum cardiomyopathy very subsequent pregnancy, so better discourage. So my question is, what is the pregnancy associated cardiomyopathy? So we all deal with peripartum cardiomyopathy. So what is pregnancy associated cardiomyopathy?
Cardio.
For audience, not listener.
Audience, participants in the audience can answer it in the chat box. I'll repeat the question. What is pregnancy associated cardiomyopathy? Now it seems nobody is willing to answer. Can you please explain it to them?
So generally, peripartum cardiomyopathy means it is during the 9th month and 5 months after the delivery. But in pregnancy associated means if the cardiomyopathy occurs before 3rd trimester, it is called pregnancy associated cardiomyopathy.
Thank you so much, ma'am.
Peripartum means itself name indicates peri-month, around the delivery, because last month and after delivery 5 months. Whereas pregnancy associated means before cardiomyopathy, if it occurs before last trimester, that is called pregnancy associated cardiomyopathy.
Thank you so much, ma'am, for that answer. And thank you so much for sharing your experience as well. We have a question from Dr. Muthu Kumar about the extubation plan of the patient. He's asking, how do we extubate? Should we plan post-op ventilation and extubate under control condition in ICU, or reverse and extubate the patient on OT table itself?
No, because patient is already hemodynamically unstable. Because by the time patient is shifted, BP is 80/40. So that's why you have given the sinotropes subclavian vein. And also, so saturation is also before coming to the OTs, it is 85 on room air. After intubation, it is increased to 95. That's why we decided, and also there is lungs are also crepitations are present. That's why instead of exhibiting in the theater, we planned for elective ventilation.
Thank you so much, ma'am. Ma'am, we can proceed with the session now.
All the
Invite-
questions are covered, Dr. Shipra?
Yes, ma'am. Questions are
Presentation
all
is
covered.
over. Presentation is complete, ma'am.
No, over.
Okay. So if there are any questions, anybody wants to ask from the audience, they can raise their hands and ask. Dr. Shipra, just see if anybody wants to ask.
Yes, ma'am.
From the audience, if anybody has raised their hands, just say. It's me. I have only raised my hand to ask a question. Okay, ma'am. Very nicely presented class on a very unique and very much on a unique topic of peripartum cardiomyopathy, which most of us as anesthesiologists and intensivists will encounter in our practice. So one question to Dr. Rishita or Dr. Devi, anyone can answer. What is the differential diagnosis of peripartum cardiomyopathy?
When talking about differential diagnosis, it includes pulmonary embolism, amniotic fluid embolism, severe sepsis, severe anemia, myocardial infarction, viral myocarditis, arrhythmias, etc.
Ma'am, we have a question from the audience.
Sorry, I was not
it is-
audible, is it? Shipra, just wait. I want to discuss that. So I'm
Okay.
sorry, I think I had muted myself. Yes, I think I was muted. So the differential diagnosis can also include congenital heart disease, valvular heart disease, diastolic heart failure in a pregnant woman with hypertension, right? These all can be the differential diagnosis. So how will you differentiate peripartum cardiomyopathy from pulmonary embolism? Suppose Dr. Rishita or Dr. Devi, either of the two. So suppose we have a case, unmute yourself. Suppose we have a case who has come in the late part of pregnancy, okay, said 36 weeks. And she has some symptoms. And how are you going to differentiate the symptoms and signs or whatever? How are you going to diagnose peripartum cardiomyopathy and differentiate it from pulmonary embolism? Unmute yourself, please. Unmute yourself. See, the main problem in peripartum cardiomyopathy is, can you hear me? You look lost. Dr. Devi?
Yes, ma'am.
You can hear me. Yeah. No, there is nothing on the screen. Don't look on the screen. I am asking the question that how are you going to differentiate peripartum cardiomyopathy from pulmonary embolism in a pregnant patient who is there in the late pregnancy?
Ma'am, mainly peripartum cardiomyopathy, it occurs in the last month of pregnancy, ma'am.
So even pulmonary embolism can occur. It can occur intra-op. It can occur anytime.
Ma'am, in pulmonary embolism, there may be acute onset of symptoms, ma'am, like SOB, shortness of breath and palpitations.
Shortness of breath can be there in peripartum cardiomyopathy also, dyspnea, right? Palpitations can be there in cardiomyopathy also.
There will be a sudden onset in case of
Pulmonary embolism.
In
But
pulmonary embolism, there can be sudden onset. Okay. Anything else? Anything else?
By investigations, by doing 2D echo and
Patient can also have chest pain in pulmonary embolism, right?
Yes,
Okay. Anything else? PPCM patient can have other symptoms like fatigue, swelling of feet and all, which can be there in normal pregnancy also. So it is very difficult to differentiate from normal pregnancy many a times. And that is why the diagnosis of peripartum cardiomyopathy often gets missed. And the patient comes directly to OT, and then we can land up with complications, litigations, and so on. Okay?
Yes.
Yeah. Any other difference? So how are you going to differentiate it now?
So in pulmonary
The
embolism,
D-dimer levels will be
will be
elevated
there.
in case of
Wait, ma'am is telling something. Yeah, ma'am is telling
So
something.
in pulmonary edema, pulmonary embolism, there should be prior etiological factors like prolonged bed rest, and also this thrombogenic condition should be there to occur pulmonary embolism. Whereas in peripartum of cardiomyopathy, need not be present these etiological factors.
Right.
So that is also one of the difference.
Yes, ma'am. Anything else regarding the investigations, Rishita?
By 2D echo and CT pulmonary angio, we can
Excellent.
detect
So
blow-
2D
blow
echo
distance
will, what
in-
will it show? 2D echo will show reduction in the
ejection fraction in case
systolic.
of
Okay, systolic
systolic
dysfunction
dysfunction
will be there.
and there
Yes.
will be enlargement of the all chambers,
Okay.
left atrium and left ventricle. Global hypokinesia of the left ventricle is
Whereas pulmonary embolism, what will it show? Okay. There will be more of a right heart strain pattern. Okay.
normal LV is seen in pulmonary embolism.
Okay. And what about the ECG?
ECG in pulmonary embolism,
we can find S1Q3 to 33.
What is that known as? Somebody has typed it in the chat box. Dr. Halley has typed it as some sign. McConnell sign.
This one.
Can you see in the chat box? Okay, so everybody is trying to help you. Anything else? Or you can also see sinus tachycardia in the ECG in pulmonary embolism. Okay. Next.
Ventilation perfusion mismatch means more towards of pulmonary embolism than peripartum myopathies.
Excellent. And then you can go in for a CT angio if it is available.
That is the confirmatory
Yeah.
differential diagnosis.
Very good. So very often it goes undiagnosed, the peripartum cardiomyopathy. Now, ma'am, one question for discussion, that suppose, is it possible that a patient of peripartum cardiomyopathy can walk in without symptoms and be undiagnosed and be taken up for cesarean section and then land up with complications and mortality? Is it possible?
Yes, it is possible.
Because there are many cases which land up with, say, a sudden obstetric complication occurs, that the patient goes into arrest, say, drop. And often it is blamed as peripartum cardiomyopathy. So how would you defend this? Like,
it is the peripartum cardiomyopathy is diagnosis by exclusion itself. So pregnancy, normal delivery or whether maybe instrumental is over. After that, during this postpartum period, after delivery, there may be some cardiac dyspnea like that. Then we have ordered for ECG and echo. Then there may be a diagnosis as peripartum cardiomyopathy without any symptoms before delivery and also during delivery.
Ma'am, what happens actually? I will tell you. Shrilatha ma'am, the one thing I will try to highlight here is, see, in our country, majority of the patients, when they develop the cardiomyopathy, peripartum, they go for the next pregnancy also, because majority of them remain a little asymptomatic during their course and they never show up to anybody. Even the antenatal checkups are very erratic in our country. Okay.
Yes.
So when they come up finally, and it is very difficult for an obstetrician to go for the cardiomyopathy, evaluation. They are not putting up the patient for any surgical procedure. So they don't send it to the anesthesiologist, who are little better than them in seeing the cardiac part of the patient also.
Yes, sir.
So suddenly when these patients come for the emergency vaginal delivery with the labor pains or something like that, then we see that the patient was of cardiomyopathy. So this is what one thing is there. Then the second part is, whenever dealing with such patients in our setup, you know, every setup is having a different type of resources.
Yes,
How
sir.
will you
Yes.
really manage? Whether you have the support, the intra-operative presence of a cardiologist or cardiothoracic surgeon in the OT to guide you about the cardiac status. Although we have a cardiac anesthesia branch fully fledged, but these type of patients are very tricky. As I told in the beginning, because there are two types of lives involved in such patients. The managing such patient, whether they go into the cardiac arrest, whether they go into the cardiac complication, is always very difficult to diagnose actually.
Yes, sir.
So ultimately what happens when these patients, and especially with the economic backward classes, majority of the labor classes, when they
Yes,
come
sir.
with
Yes.
you, come to you in these things, and if you are working in a government hospital setup, sometimes the resources are not adequate. The medications are not that much adequate that you will be able to treat this patient like in a corporate sector. Here you have to get the medicine from the pharmacy outside, and the patient may not be having that much budget to get the medicine also. That is also sometimes difficult,
Yes.
and
Yes,
our
sir.
buffer stock may also deplete in the due course of time. So such cases are basically challenging not just because of clinical side, because of the literacy side, the lack of awareness, then the psychosocial side, and other factors. These are contributing to the mortality of these patients. Otherwise, if they come clinically, the anesthesiologists are the best person to plan the deliveries as well as the what we call the sections also in these patients. So this is the irony of the peripartum cardiomyopathy or any cardiac disease in pregnancy in our country.
That's why the mortality rate in peripartum myopathy is 15 to 30% mortality rate. Whenever we find after delivery, any component of cardiac problem is, we have to exclude the peripartum cardiomyopathy so that we can advise for next pregnancy.
Yeah,
So
even
that we can avoid this maternal mortalities and infant mortalities.
yeah, it can happen even in the best of the hands also. Because I've seen two cardiac arrests in my life when I was associate professor. So I've seen two deaths on the table with the cardiomyopathy patients when they went for the operative delivery. So very difficult to decide the GA course or the spinal epidural, whatever the course is, those patients. So I think difficult, but I think with the knowledge shared today, as well as the books, if you go through them, then it will be easy to plan the anesthesia for such patients. As Dr. Madhuri was also saying, every bit of the part, the pathophysiology of such patient is very important in evaluating the patients.
Yes, okay, sir.
And Dr. Shipra, the class is over or still left, some part left, some questions?
So we have a couple of questions left.
Yeah, please
Uh,
carry on.
yes, sir. So Dr. Sakshi is asking, can we use Lasix? Are they safe in pregnancy?
Like, yes, we can give.
Why they are unsafe? First of all, the Lasix are the cornerstone of many of the diseases in the pregnancy. I think there is not an issue. I think the question would have been asked whether they are safe in the case of peripartum cardiomyopathy. That would have been a better framing of the questions.
In case of peripartum also we can give lashes to
Yeah,
avoid this overload and all, and also to prevent this pulmonary edema and all.
Thank you, Mom, for answering it. Ma'am, we have another question. How can you differentiate pregnancy-associated cardiomyopathy with already pre-existing cardiomyopathy?
I already told peripartum cardiomyopathy is exclusively in the last month and also 5 months after delivery. Whereas pregnancy associated means it cardiomyopathy associated before pregnancy, but should be after, before third trimester. So only the duration, management is same, but the duration, if it occurs last month of pregnancy and 5 months of, post delivery, that is peripartum. Name itself is around the delivery. Whereas pregnancy associated means cardiomyopathy is same, but if it occurs before the third trimester, that is before 9 months.
So, but I think what they're trying to ask is if the patient, before conception, if the patient had a cardiomyopathy and what was not diagnosed, so how will you differentiate it? Like before conception, patient had cardiomyopathy, and another patient who has developed it after pregnancy in the first trimester.
very difficult. Shipra, very difficult, I'm telling you. The patient, I told you in
Yes,
the
sir.
my part also that they never show up to the clinicians or the obstetricians. They may come
Yes,
to
sir.
the hospital for the first baby, their symptoms for that. The strata of our, especially these prevalence in the villages, where it's very difficult to diagnose at the last stage. So invariably, these patients remain asymptomatic till they go to the second trimester or little later than that. when the symptoms start developing in the real sense of the word, So very difficult to diagnose. You can't say that the patient has been diagnosed or patient is that much intelligent that they've come to know about their cardiac status. Even many, if you ask about the learned people, you talk about the hypertension, you talk about other things. Many people may not be knowing they are having. They will try to deny it. They will try not to take any antihypertensive. That no, मैं ऐसे ठीक हो जाऊंगा. I will get all right like this only. So there are so many perceptions and beliefs and traditions going on in our society that is a hindrance to the accurate and precise as well timely diagnosis and intervention in these type of cases.
Thank you so much, sir, for answering.
So
Are there any more questions from the audience?
before that, I think I will like to
Yes,
go for
sir.
a little bit of felicitations.
Yes,
So
sir.
first of all, Dr. Vinay Kumar sir, thank you for bringing the team for a very, very important topic. So thank you very much, sir, for being the part of this and the team leader of this team. And Srilatha ma'am, thank you very much. I think your efforts and Dr. Snehata madam's efforts, they are wonderful in preparing the PGs and that too second year PGs for such a good topic and difficult topic, clinically difficult. So thank you both of you ma'am for being
Thank you,
the moderator for this particular class. And Rishita as well as Devi Abrahami, the both of you did well. And the best part is you did not make any blunder, which is always required in such classes. I think that you should carry the same tempo in your final examination, practical examinations also, because there also the examiners like you can always quote that we had given online Viva madam once, so though you will get at least 2 to 3 marks for that also, and Dr. Shilatha madam will be endorsing your efforts in the final examination also.
Thank you, sir. Thank you for the opportunity also, sir.
Yeah. Shipra, thank you for being a wonderful anchor for this class. I think you did a wonderful job today. So it
Thank you,
will
sir.
it'll also bring some confidence into you to go into the as a young national faculty going further, isn't it? Yeah.
Yes, sir. Thank you so much, sir.
Yeah. Thank you, everyone. So
Thank
now
you,
you
sir.
can go to the question answer if any left, Shipra.
So there are no questions. Anyone in the audience, if they want to ask any questions, please type in the chat box. There are no more questions.
Somebody has
But
mentioned, Dr.
Yes,
Shipra,
ma'am.
somebody has mentioned something
Yes,
about
ma'am.
Clark's criteria. What is that? DD of question of amniotic fluid embolism.
Yes, ma'am. Dr. Thakur Bhai has made a statement, more of a statement, that there was a DD of a question of amniotic fluid embolism, and they wanted just want to emphasize that Clark criteria must be remembered.
Amniotic
Dr. Rishit.
will occur while there is over distension of the uterus, like twins or hydromyopathy cases. In that, during contraction, what happens is the amniotic fluid will break some due to because of these contractions. There is intra-abdominal pressure that will cause the amniotic fluid enter into the vessel. So that will cause the amniotic fluid embolism. They tried is cyanosis. Breathlessness is a presenting feature. Within no time, they develop into cyanosis. So one arrest. So prognosis is very bad. So these are the generally diagnosis we will miss the amniotic fluid embolism. There is no diagnosis. To think over, we will put it as amniotic fluid embolism. So by knowing the etiological factors like this over distension of abdomen, where there is intra-abdominal pressure will be more, so that may be the cause. So we can think of that. This may be due to amniotic fluid embolism. It can occur during during the onset of labor pains and also during surgery, where there is chances of entering into the vessel. Amniotic fluid will enter into the vessel.
Hello, madam.
Dr. Thakur Bhai, yeah, please.
Good evening, sir. Good evening, madam.
Good evening.
Good evening,
There
sir.
is an answer by someone regarding the differential diagnosis of the peripartum cardiomyopathy. That was given. That was the regarding the pulmonary amniotic fluid embolism. Here, the criteria must be kept in mind. This amniotic fluid embolism typically presents during labor or just within half an hour of that labor. After half hour or 1 hour, we cannot have that. It will be other diagnosis. So amniotic fluid should be within that period only and associated with other sign symptom like shock, even allergic reaction can also be there. And it is typically response with the steroid, Dexona, and other supportive treatments. So amniotic fluid embolism after 1 or 2 hours of the delivery, it is ruled out as per the class criteria.
Thank you so much, sir, for the information. I noticed Madhuri ma'am had raised her hand again.
No, I was going to add to that amniotic fluid embolism. Yeah, that's it. But just I wanted to ask Srilata ma'am. Ma'am, in case we do not want to miss the diagnosis of peripartum cardiomyopathy, would you advise doing 2D echocardiography in pregnant patients who are taken for cesarean section?
So if there is no other cause, we can to exclude.
No, I mean even if there are no signs and symptoms.
Without
think
any
Should you do 2D echo in the patient?
If
Dr.
there are
Madhuri,
no,
Would
this
you
is actually
routinely advise doing it?
no, Dr. Madhuri, it's
no.
basically a policy making
And there are
decision of
only signs and symptoms
institute
we
to
will
institute. It's institute to institute actually varies. From
Okay.
one institute they will be doing it, another institute they may not be doing it. Also depending on the availability of a good cardiologist who is well versed with the obstetric cases, also whether they want to do it. Because sometimes what happens, even the PCP and DT Act, you cannot take the echo also from one place to another. They have to be like just like have to be kept in one place. So many factors are there, and invariably the echocardiography question will always remain. But whenever we see, I think whenever the patient comes to the anesthesiologist for any intervention for painless labor or for the vaginal delivery or for even for that section, I think when we evaluate, so we should go for the echocardiography. That is a must. That will help. That will help us planning of the anesthesia also. But again, I think it's a policy decision depending on the protocol for each institutes. If the institution is good, they will definitely go for it. But majority of the people, they go to the civil hospital, they go to the PSCs. You never find the echo. Many of the peripartum cardiomyopathy patients are shown there, and they are hardly referred. Many times they are not referred; they are dealt there only because the load is so much on the tertiary cares that the deliveries does occur there only.
Yes, sir.
So I
Thank you
think
so much, sir.
Yeah. I think it's the time now. And I really thank the team of Vijayawada, Siddhartha Medical College, Dr. Vinay, Dr. Srilatha, Dr. Snehalatha. Thank you very much, and the PGs. And my team of Dr. Madhuri, Dr. Nishant, and Shipra, we did a wonderful job for carrying this class. And after this class, it will be available on the ISA NHQ at YouTube channel. It will remain permanent there, and it will be a national class asset of our ISA digital library of the PG classes and accessible free to everyone. So Rishita and Abrami, you will be and embalmed into the books of digital library of ISA permanently along with your teachers. So this is a way going forward. So thank you, Vinay sir, for
Thank you, sir.
bringing
Thank
your
you very
team
much.
here. Yeah.
Thank you so much, sir. We are very grateful to you, sir.
Yeah, sir.
Thank you, sir.
So welcome,
Thank
ma'am.
you, sir.
And so
Thank you,
we
sir.
leave the stage always by saying long live ISA.
Long.